In broad terms of the role of CNIs in DSA formation, what do we know and what are we still figuring out?
Well, it's interesting that even before we knew about the role of donor-specific antibodies in acute and chronic humoral rejection, there were data from randomized controlled trials suggesting higher rates of acute rejection when you attempted to withdraw or eliminate the calcineurin inhibitors from kidney transplant recipients. And a lot of those studies were done in an era where we didn't recognize the difference between T-cell and antibody-mediated rejection, but it seems likely that some of those rejections were humoral in nature and that DSAs were involved. You know, the problem is that there's similar data from trials or clinical experiences where other drugs have been reduced or eliminated. There's been a long-standing literature on reducing mycophenolate mofetil in kidney transplant patients showing higher rates of rejection, and we now know that some of those rejections are antibody-mediated. I think what we're still trying to figure out is whether one class of agents is more important than the other in terms of this role of withdrawal of the agent causing DSA formation. And, clearly what we don't know is whether there's some threshold dose above which you don't get donor-specific antibodies and below which we do. That's the big trick in all of transplantation, is knowing whether we have just enough, too much, or too little immunosuppression.
What are the current treatment options to prevent de novo DSA formation?
So as a corollary to the answer to my first question, I guess the answer is maintain adequate immunosuppression. That's the key to preventing DSA formation. But again, what is the definition of adequacy? There have been some attempts to prophylactically or preventively use anti-CD20 antibodies, rituximab. There's an experience in heart transplant patients that I think has only been published in abstract form to date. And that study is negative, meaning it did not help to prevent de novo DSA formation. In fact, it may have had a paradoxical reaction in the group that was randomized to rituximab. So I don't think we have any novel therapies available to prevent DSA formation other than maintaining adequate levels of the current drugs that we have. Locally, we decided several years ago to abandon what was once a common practice in many centers of avoiding calcineurin inhibitors in the early days after transplantation in patients who had delayed graft function. I don't know if this has been studied rigorously, but certainly we and many other centers have changed that policy and now try to get calcineurin inhibitor levels up to therapeutic levels early after transplantation, even in patients who have delayed graft function. So there have been some changes in strategies which all recognize the importance of having adequate calcineurin inhibitor exposure on board early and throughout the course of the post-transplant period.
Describe the role of adherence to CNIs and steroids in the prevention of DSA formation.
Well, we all recognize that non-adherence is a huge problem in transplantation in general, and we've all recognized for years that non-adherence can lead to rejection. Probably the best experienced answer to this question came from Edmonton a few years ago, where they looked retrospectively at their causes of long-term graft loss. And of course, this is Phil Halloran's group that has promoted this idea that antibody formation or DSA formation is probably the leading cause of long-term graft loss. And that's indeed what they showed at their own center. More than half of patients losing their grafts in long-term follow-up had donor-specific antibodies. The interesting sub-analysis that I'm referring to was one that looked at the role of non-adherence, and almost 50%, I think 47% was the actual number of patients who developed antibodies were patients who had clear-cut evidence of non-adherence, not subtle non-adherence, but overt non-adherence with not taking drugs. So that study confirmed, I think, what we've already known about non-adherence and rejection, but was the first to focus on the role of non-adherence in promoting DSA formation. The bottom line is whether drugs are minimized by the intent of the physician as part of a protocol or by the intent of the patient because of their non-adherence. Minimizing these drugs, but particularly the calcineurin inhibitors, is clearly going to result in the generation of DSAs in some fraction of patients.
The tacrolimus withdrawal study, in which you were the lead investigator, was prematurely terminated by the Data Safety Monitoring Board due to unacceptable rates of acute rejection and de novo DSA formation in the tacrolimus withdrawal arm. Can you tell us a little bit about this study and what it means in terms of our knowledge of the role of CNIs in DSA formation? Specifically, why was tacrolimus withdrawal associated with immune activation?
So you're referring to the CTOT-09 study. This was one of many studies in the clinical trials of organ transplantation initiative sponsored by the NIH. CTOT-09 was a randomized prospective trial in which we enrolled patients that we perceived to be very low immune risk. Namely, all of them were living donor recipients who were non-sensitized at the time of the transplant. Most people would agree that that's a low-risk population. Despite being low risk, they were treated aggressively early on. All received induction therapy with rapid anti-thymocyte globulin or thymoglobulin. And all patients received at least low doses of steroids and tacrolimus and mycophenolate mofetil. And the doses were pretty much standardized so that it was homogeneous. The patients have to be free of rejection for 6 months, and at 6 months have to have a biopsy which was entirely clean with no evidence at all of rejection. And only then were they randomized into a group that was maintained on tacrolimus and another group that was slowly withdrawn from the tacrolimus. Now, you're right, the study was aborted by a data safety monitoring board only after 21 patients were randomized, and the randomization was in a 2-to-1 fashion. So there were 14 patients who were randomized to come off the tacrolimus, and after a very short period of time, it became clear that more than half of those patients either developed rejection or DSAs. Now, the purpose of the study was to demonstrate that immune monitoring could help facilitate the safe withdrawal of tacrolimus. The immune monitoring that we were focusing on were certain urinary chemokines that we had previously demonstrated to be correlates of rejection, particularly CXCL9 and CXCL10. And in fact, the immune monitoring worked. After tacrolimus was withdrawn, we picked up the rejection episodes before creatinines rose by finding elevated levels of these chemokines, resulting in biopsies that showed the rejection that I'm talking about. So you could argue that the study was a success, but the outcomes were more important in the group withdrawn from tacrolimus than the control arm. That's why the DSMB stopped the study. The temporal association between rejection and DSA formation was the scary part. The problem is that this ended up being a very small study with those small number of patients I meant, so one can still argue that we haven't done a definitive study, but it is what it is. The DSMB didn't allow us to proceed. Now, to answer your question about insights into how tacrolimus might be associated with immune activation, the calcineurin inhibitors are unique amongst all the maintenance agents that we have now in terms of preventing memory. And memory, whether it's T-cell or B-cell memory, probably is very important in the long run in terms of preventing immune activation and DSA formation. In that regard, we did a post hoc analysis in CTOT-09 looking at one measure of memory before the transplant, and that's the donor-specific ELISpot assay for interferon gamma, an assay that was sort of developed at my center 10 or 15 years ago, but we incorporated CTOT-09. When we look retrospectively at the small number of patients, indeed, patients who had donor-specific memory based on that assay pre-transplant had higher rates of either DSA or rejection. Again, the numbers of patients were small, but the trend was alarming. We also showed that HLA epitope mismatching for DQ prior to transplantation was predictive of who developed a DSA after tacrolimus withdrawal. So if we were ever to do that study again, and God knows it would be difficult to convince people to do it since the results were so bad, but if we were to do it, we would probably only randomize patients who were ELISpot negative prior to transplant and who had HLA epitope mismatching below the threshold, which I think was 16 epitopes, because patients with higher levels of epitope mismatching and patients with positive ELISpots are probably those patients who are at highest risk for getting DSAs when we withdraw the calcineurin inhibitors. So there's a lot to be learned from what some people perceive to be a negative study.
Can you differentiate between complete elimination of CNIs and minimization of CNIs?
I wish I could, but I don't think I can. It's a very important question. As I indicated in the response to one of the earlier questions, I think one of the things we don't know is what the threshold is for CNI exposure above which you don't get DSA formation or rejection, or below which you see those immune events. I think that there have been multiple efforts from many trials to lower CNIs with some success, but still in some of those trials you will see more rejection when you minimize the CNIs compared to the control arms left on higher doses. But in general, this is probably one important avenue to pursue. If we're interested in getting rid of CNIs because of their side effects, namely their putative nephrotoxicity, their cardiovascular side effects, this is still a reasonable strategy. Maybe we can use half of what we used before and still see the immunologic benefits of these drugs being on board with lesser side effects. But I think that whole concept remains to be proven.
What did the Symphony study teach us about CNI minimization?
Well, at face value, the Symphony study, as you know, had 4 arms, and 2 of the arms were considered to be low-dose CNI regimens, and the one arm, the most controversial arm, was a group of patients who received sirolimus and no calcineurin inhibitor. And again, so there was one group with no calcineurin inhibitor on board, and that was the group that did the poorest in terms of highest rates of rejection, lowest GFRs in the long run. I mean, their controversy over the Symphony is, first of all, in that arm, the sirolimus doses were low and the target levels were lower than what are used in clinical practice. The other arguments are that in the minimization arms, the levels that were being aimed for in that study are really not that much different than the levels most of us are using in clinical practice. The importance of the Symphony study is that it pointed out that the combination of tacrolimus in relatively low doses and mycophenolate mofetil is hard to beat amongst all the other drug regimens that we've tried in the past decade or so. It, I think, just supports the concept that elimination of calcineurin inhibitors is a bit dangerous. And it gets back to that last question about maybe lower CNIs are safe and better than what we used to consider full doses and higher exposures of those drugs. So Symphony taught us a lot, but there were some flaws in its study design.